Thank you very much, Anne and Brendan, for a fascinating session. Some of you may have already found we're encouraging audience participation today. We're using a system called Slido, which is really simple to use, and it's a Q&A within the Web Health Conference app. So if you go onto the Web Summit app, if you click the Slido Q&A, and if you go to the Health Conf stage, if you have any questions, simply put them in there. And in the next session, we're going to be using an interactive vote as well. So for the next session, knowledge is power, and power means money. What if we have the power and the knowledge and the money? Up next, we're discussing one thing left to commoditize, our health data, exploring the challenges, threats, and opportunities that come with collecting human data. Please welcome, led by Paul Nuki from The Telegraph, Mona Siddiqui, the Chief Data Officer in the US Department of Health and Human Services, and Dean of Dell Medical School, Clay Johnson.
I know.
So, good afternoon. Thanks for coming to talk about data and who owns it. Mona and Clay have done a huge amount of thinking around this subject. It's a subject that's right at the center of the development of tech and health. If we get it right, great things could happen. If we carry on, I think, where we are at the moment, where people struggle with the ownership of data, it will slow things up enormously. So let's start with the really basic question. Who owns the data? Is it the patient? Is it a doctor? Is it the insurance company?
Do you want me to start?
Go ahead.
Well, so you know, the reality is that it should be the patient. The patient, it really has the most invested in what is in that data set. But the reality is that's not the way our system works, at least certainly not in the US. So really, ownership is not so clear. We have rules in the US where a patient can get access to a copy of their record, their electronic health record. They certainly don't have rights to edit that record. Logistically, it's extremely difficult to do that. And even when the government's holding that data, there's no guarantee that an individual can get that data back from government.
Yeah. So at the moment, if you put your health data out there, you can't pull it back. And Mona, what do you think? Do you think we should view ownership as the ultimate thing, or is it more complicated than that?
Yeah, no, I think we have to be really precise about the words that we use, especially in this space. And increasingly, I find that we're not. And so what does ownership really mean? To Clay's point, does ownership mean access? Does it mean the ability to edit? What are the implications of each of those ways of being able to access your record? And also, how are we defining healthcare data? We can look at electronic health record, and that has a certain set of data. But I think we also have to acknowledge that a lot of the information that exists out there about our health and about the ways in which we want to access health or health information isn't in the EHR records anymore. It is through social media searches and many other ways that aren't regulated in the same way, in the same very strict ways in which EHRs are regulated. And so I think defining those words and the implications are really, really important.
So there'll be some developers and some CEOs out here, I'm sure. They'll be maybe worried hearing someone from the US Department of Health saying we should broaden the definition of health data. Do they need to worry, do you think?
I think that I think there are a lot of things that we have accepted without addressing very explicitly. So the norms around privacy, around the way in which third parties use the data that we are providing through the ways in which we access services. I think those have all been a given in many cases without having an explicit discussion about the individual rights to that information. And I think that that needs to change. I think that there has to be an explicit discussion for how consumers should be able to track the use of their information along the chain. And there's a difference in a government entity collecting data where the implicit purpose is for a greater social good. And when you sort of leave those boundaries and those norms, the same principles that we operate under don't apply outside of the federal government space. And so if that's not the case, what are the things that we're implicitly accepting? And are we okay as a society accepting some of those standards? That discussion needs to happen in an explicit way.
Clay, what's your view on how the debate is moving, both in the US, Europe, and further afield? Do you think we're making good progress in better defining, better legislating for the use of health data?
Well, I think, obviously these are complicated issues. One wants to feel secure that one's health data is being protected. On the other hand, I think that we've pushed things so far. Is that the rain?
I think it's the rain, yeah.
Or are you all just clapping so loudly you can't even hear ourselves? Right now, I think that there are many more potential positive uses for data that we're not allowing because we've been so concerned about privacy. So, one example is email. It's at least in the US, it's extremely difficult to email your physician. Even though, half of patients are not taking their medications as directed 6 months after you prescribe them. And many of those issues could be addressed very readily with email. And could an email get disclosed or discovered somewhere? I think for most of us, we wouldn't care. Doc, you prescribed this drug, I'm having headaches. Could it be from that drug? We wouldn't care if that became public. And yet we've restricted that kind of communication so severely that we're not benefiting from sharing and more openness in data. That's on an individual basis, but also on a global basis as well. So
some of the best things in tech are maybe being blocked by concerns about data. I don't know if people in the audience have examples in their own businesses that they might want to put on these question screens here, where they think that poor legislation around data is preventing their businesses, their tech businesses, from growing. If you do that, I can pick some of them up as we go along. Just going back, Mona, to the definition of health data. Maybe you could just tell us at the moment how the US formally defines health data, and the sort of areas that one might see it covering in future. So movement data from my steps, specific genetic data, insurance data, I don't know.
Yeah, so I would say, just to start off, I think a lot of federal government departments like HHS are actually big data organizations without embracing their big data identity. We just haven't thought about how we create the infrastructure to be able to use the data that we have. So within HHS, we have NIH, we have CDC, we have CMS, we have FDA. These are all collections of an enormous amount of both research information as well as access to care information, outcome information that we've collected for 30, 40 years. We're also doing a project right now called the All of Us Research Project through NIH, which is attempting to collect data on 1 million lives and both traditional data sources from an EHR, but also other information such as wearables, again, to try and longitudinally follow individuals and look at disease outcomes and progression over time. So that's been really the sphere of kind of how we're looking at data, EHR data, and the information that we traditionally collect. I think increasingly there's so much information that we access outside of the normal ways in which we think about a patient-provider interaction that doesn't get captured by the healthcare system. And as the ways in which our access to care changes over time, either through the use of different technologies or the fact that, as you look at sort of the ways in which younger people are accessing care, they don't have a primary care doctor. They're looking at other ways of being able to quickly get access. Well, how's that information getting translated in the ways in which we are looking at population health? And so our definitions of healthcare data should also start to encompass those non-traditional data sources, whether it's social media searches or other things that we haven't been looking at. But I think it's an evolving landscape. And like most things in tech, the regulatory landscape will be much further behind where the technology and data access are going.
So just looking at some of the questions from the floor here, so there's one right at the top there, where we're talking about who owns the data, but shouldn't we be talking about access to it? How do you see that, Clay? Could there be a sort of licensing regime ultimately for access to health data?
Yeah, I guess, maybe that would make sense. I have to think about the access, but again, I think one would like to know how one's data is being used, right? Currently in our systems, we don't really know that, and a whole variety of places in which we share data, including in the health system. On the other hand, I believe that there are many more positive uses of the data than negative uses, and that our current bias is restricting us from doing much more positively, whether it's development of new therapeutics, whether it's screening and prevention, whether it's outbreak identification, whether it's sharing information about our own allergies, so when we show up in an emergency room, we're not given a drug that we shouldn't be, whether it's when I go up having to say that my gender hasn't changed, and I realize that is possible that it could, but having to fill that paperwork out over and over again to say, yes, my birth date hasn't changed, my gender, all of that stuff too, we are encumbered by because we haven't figured out a way to share the data when it's in our best interest as individuals to share it. Financial data is very different, right? I just used my ATM out here in Lisbon to get some euros. That somebody knows how much money I have in the bank. Oh my goodness! They also can know, all these things that would determine my credit. Where I spend my money, whether I have a loan, how much in debt I am. All those things are shared. We accept that they're shared, and they're shared for our common good, with some risk to us, but it's managed. And I think we need to have a similar notion about health data as managed.
So maybe with health data, we're overly and unnecessarily sensitive to what's out there. And different cultures do approach this differently, I think, right?
Yeah, I think there's some things that, would I give everyone access to my entire DNA code? I'd like to know why they wanted it. But I wouldn't necessarily be, as a physician, I still wouldn't necessarily resist that. I know there are concerns about coverage. Will I lose insurance coverage for that? Well, our laws ought to handle that. We ought to say that you shouldn't be able to deny insurance for prior health conditions. So there are other ways we can manage that. Frankly, I should disclose that anyway when I apply for insurance. So I think that, again, it's very important to think about protecting health data just like we think about protecting other data, but I think that we've done it in an irrational way and have used it as an excuse in moving the whole big data opportunities forward in the health system.
Right. So, sorry, Mona, yeah.
So a couple of points, and I would agree with most of what Clay said. I would say that when we look at developing regulations around the use of data, my what I've learned over time is I think the way of approaching it has always been, how do you protect the people that are most vulnerable in the population, right? So we have very specific ways in which behavioral and mental health data can be accessed or not accessed. When we as the federal government are trying to address the national opioid crisis, there are ways in which we're prohibited from being able to access the data that we collect because of some of those laws around behavioral and mental health data. And so part of it is that there is this bias towards trying to protect those who just can't protect themselves, or who, if their information was accessed, would be the target for either community judgments. I mean, you saw the same thing with the HIV/AIDS epidemic as well. So that's one. The other thing I would say is that at the department, which is about over $1 trillion organization, 90,000 employees, and 29 different components, we're grappling with the same issues that people are grappling with outside of the department, which is that we're working within a landmine of different regulations that different parts of the department have to follow. And how do we actually get to a common understanding so that we can share data across those 29 different agencies, which, shockers of all shocks, right, that we can't actually in a very seamless way. And if you want your government to be an efficient and effective use, have an efficient and effective use of dollars in how we manage our resources and how we provide access to the best care, the fact that we are not actually able to, in a seamless way, share the information that we have, that is unacceptable. And so getting to that common understanding over time and the common interpretations of things that exist, which we haven't done for many, many years, needs to be addressed.
I think that's a great, I think that's a great point, because I think that's one of the major barriers, is that we have institutions, even outside the government, that are interpreting regulations differently. Yeah. And the easiest thing, the lawyers are telling them, just don't share the data, don't make it accessible. That's the safest thing you can do. So we actually ended up, and this addresses this question number 2 up there. We, every American city has a homeless problem. Every major city has a homeless problem, whether they acknowledge it or not. And we do in Austin. And the homeless actually are horrible victims of a lack of sharing of data, right? Because they show up in different emergency rooms. They can't have their records. They don't have a family member necessarily that's bringing them their records. And so they get treated for the same things over and over again. There's no medical history known. Things are repeated. They're really poorly treated. So we actually got a grant to use blockchain to solve the problem for healthcare records for homeless. It's an experiment, and it's still early. I can't tell you how it's going to come out. But the reason isn't that a homeless person wouldn't say, you guys share all my data. The vast majority, I'm sure, would say, you guys just talk to each other, you figure it out, you take care of me when I come in. But the reality is each of the systems in which they touch is not willing to do that. But blockchain allows us a vehicle, so the patient owns the blockchain code and the data is dumped in on every visit. So I do think that really what we're doing is developing these security systems to solve our regulatory issues more than we are deeper societal issues about true risks associated with data sharing.
So you've both talked a little bit about preventative health, and big data has some huge possibilities in that area, whether it's around the homeless, it's HIV, it's pandemics. And both of you, medics by training, I think, you're the good guys. And there's a sort of assumption in here that if we release this data out there, the good guys will do good things with it. But do we need to be worried, do I need to be worried as a cynical journalist or a patient, that maybe not everyone is as benign as you guys? And do we risk letting the genie out of the bottle and then finding some really bad guys pick it up?
So yes. I think, again, we have to have a common understanding of what are the norms that we can all sort of accept in this space. But to say that we will be so risk averse as to take zero risk That's just not possible. And so what is the level of risk that we're okay taking? Because disclosures will happen. We have to do our best to protect the privacy of individuals while still enabling that information to be used in the ways in which it should be used for promoting care. So yes, I mean, we should not let a risk-averse stand prevent the use of that information. But we have to get to that point of understanding what is that level of risk that we're okay with.
And we've got to somehow agree that as a society, right?
I'm sorry?
We've got to somehow agree that level of risk as a society.
We do, and then the other thing is that when disclosures do happen, unintended disclosures happen, we should pause and understand why they happened rather than scapegoating systems and individuals when that has happened. Of course, if those guardrails aren't there and those things occur, there's an institutional problem that needs to get addressed. But if you've taken some of those steps and those disclosures occur, well, we need to figure out why and what can we do to address it rather than scapegoating.
Yeah, I agree. I mean, I think there's some uses that, well, it's just, the positives are really obvious and it's hard to imagine a negative. So truly de-identified data used for outbreaks, influenza tracking, Ebola tracking, those sorts of things, I mean, it's hard to imagine that the risk of a nefarious use would outweigh our interests as a society in sharing that data. And then there are others where it gets a little more nuanced or balanced. Like the details in electronic health record or DNA data that's around an individual, I think there's a lot more sensitivity around how that might be used. But I mean, the reality is we treat health data as though it's some special thing. And we share all kinds of data everywhere. So, anyone in the audience can know where I live and come visit me at my home. When that was first, when phone books first came out, I'm sure someone was really nervous about that. Somebody's going to come to my house. And we've managed that risk. I think we have to have a similar pragmatic approach to thinking about what are the true risks and what are the potential benefits, and allowing what is an incredibly information-intense industry to fully utilize the information that it has.
Yep. So I can remember the days of phone directories, and you used to have something called X directory, and it was very bad news for journalists who wanted to track people down, and people made businesses out of creating X directory numbers for journalists. Mm-hmm. So there's another blockchain question here. Blockchain is potentially a really powerful technology in this area. I think that there's some work being done with blockchain around genetic codes. So you can share your genome into the blockchain, but always be able to pull it back. I mean, you've worked a little bit with it. How easy is it?
How easy is it? So, I mean, I would say we're just getting going, and it's not the technology that's the issue, it's the societal and legal issues around it. Just how can we share, what does it mean to pull the data in, how accessible is it to pull it out? So the technology is less of an issue than how does that work itself into the healthcare system. I mean, we still have in the healthcare system people saying, I will use my electronic health record and nothing else. And so we still have to deal with, the conduits for these kinds of things in and out of existing health records.
Yeah. There's also a question there about the idea that people should be able to donate their health data to researchers in much the same way that an organ donor, I think is the question, makes that decision themselves, Mona. In the UK, I think they've just changed things around so that we will all be opted into organ donation, but we all have the right to opt out. And I don't know if that sort of default position might be a solution to health data, that by default, we're opted in as citizens, but given the option if we want to come out.
Yeah, so I think the U.S. has not historically been an opt-in society. I think we default to opt-out, and then people can opt-in. I don't know that we are there yet to be able to change that. I think a lot of the ways in which we currently access technology and information are, I think, starting to create some of these norms where we can maybe over time become more comfortable being an opt-in culturally. But I don't think that we're there yet. And I'm looking at the time.
The time is up. Thank you very much for listening to this talk.
Yeah. Thank you all. I guess that.